you broaden the number of people who pay, and you chip away at social solidarity. You chip away at the morale of the people who are paying, the working people, to start resenting the people they're paying for. Yeah? That's what happens. Why am I paying? I'm never sick. I'm never sick. Why am I paying for these old people who are living too long? Yeah? So charging is a mechanism for breaking down social solidarity. It doesn't generate as much as it costs to collect.
I saw it yesterday, a couple of days ago in Sainsbury's at the pharmacy, and I've never noticed it before. There was a sign that said, not all benefits exempt you from prescription charges, or something of that ilk. And if you claim fraudulently, you can be fined up to £1,000 or something.
Yeah, so the rhetoric is being ratcheted up.
Yeah.
So if you have celiac disease now, you're not entitled to get gluten-free stuff on prescription. And the number of things that will be reduced or removed from the NHS is increasing. But each time they do that, they demonise the sick. Oh, you're not allowed to bring your child to get moisturiser eczema cream because you can buy that over the counter. Well, tell that to people who can hardly afford to eat. But each time you put that message out, the resentful taxpayer says that's good, that needs to happen.
But sometimes it's cheaper to buy stuff over the counter than get it off the
Not if you don't pay.
No.
Yeah, if you're buying paracetamol, like they said, you go and buy it for 20p a packet.
But then if you get free prescriptions, but if you're eligible for free prescriptions, then you would be paying 20p for paracetamol that you could get free on a free prescription.
In the
the
last
prescription, if I had to pay for it, it would cost, I don't know how much.
£9.50 now.
But if you're
Can't get an
eligible,
appointment.
yeah, but I suppose the point is if you're eligible for free prescriptions through benefits, age, disability, whatever, then you can get your paracetamol on your prescription.
Yeah.
But they're kind of more and more saying, well, no, you can't because it's.
But then you're paying you get a £10 prescription for a 20p packet of pills, which doesn't make sense.
You're not because you don't pay for your prescription.
No, but the taxpayer does.
But you've been brainwashed into thinking that.
So this is an example of a breakdown in social cohesion.
Yeah.
In the last 15-20 years, the number of people who have come to me just to get a prescription of paracetamol, and for no other reason, I can't count on one hand. Yeah? The people who do come with a sick child, it's normally for a child who's got a fever. To put me in the position where I have to argue with the parent of a sick child for something that costs the NHS pennies, is an argument not worth having. But you educate the parent while you're there, that maybe you could have got this next time. So the general population shouldn't be getting into the relationship between the doctor and the patient, and the politicians should certainly not be there. But it's building a resentment. That's what it's about. It's building a resentment, and it's working. Yeah.
But do you, as a GP, also are there certain things now that you're not allowed to prescribe?
Yes.
Such as paracetamol. If I came along today and said, "Can you prescribe me 50 paracetamol?" you would have to say.
You wouldn't come like that.
No.
You wouldn't come like that. It doesn't happen.
No.
It's a complete fiction that this is happening. So it's an erroneous argument to be having. Yeah. Certainly where I work. If you have continuity of care, you have respect between the doctor and the patient, this sort of abuse does not happen.
No.
Yeah?
Okay.
Because they have respect for the service they're using. The more the care is fragmented, the more people are under the cosh because of other social pressures, maybe the pressure for this increases. But you can manufacture and engineer all these things to occur. Equally, you can educate people and keep the relationship very pleasant. Yeah? So all is possible, but it depends on the dominant narrative within society. Health credits. What are health credits? Health credits are a device which in due course will be given to everybody the option of, let's say, your NHS budget, you have control of it, and you will be able to transfer it to a private insurer and top up. That's the concept of a health credit or a voucher system. Yeah?
So you get £1,000 worth of vouchers a year, and if you want more than that, then you
Yeah,
buy
so
the extra.
so when it comes to the point where everybody thinks the NHS is a basket case,
Yeah.
You, because you're thinking, well, I need to look after myself, I'm going down the road to Virgin and I'm taking my £2,000 NHS voucher with me and I'm going to top it up.
Okay.
And that's when you get the two-tier system developing.
So that already happens in social care though.
Yeah, same principle. Same
So
principle.
I
Doesn't
know
make
what
it
the
right.
Social services said, no, I know, I
Yeah.
agree. And it's misused and misspent as well.
And there's loads of bureaucracy and gaming involved, yeah? At the moment, the element of health credits that is out there is something called personal health budgets.
Mm.
And a personal health budget is a very generous fund given to the sickest in society, let's say 5-10% of the sickest people, a generous amount of money to keep them happy, but more importantly, keep them away from going to the insurance company, because it won't be transferable in their case, keep them away from the insurance company, thereby avoiding bad headlines of, I can't get insurance, I was rejected. Do you see how clever this is?
Who are those people?
The sickest. So people with chronic pulmonary airway disease, diabetics, people with transplants, all sorts of things.
Right, okay.
So every local authority, combined with local CCGs, are actively going around hunting for the sickest of the sick to offer them a personal health budget with which they can do as they wish.
Okay.
Now they've tried this in Holland.
Part of that.
It's happening. Take my word for it.
And if what they give them, is that enough to buy what care they need then? Healthcare.
At the beginning it will be. So there's a critical point whereby you keep these people very happy for a while, you get the middle class drift over to the private sector, then you can dump these people because the job's done. Yeah? You don't warn them, you make it sound great. Oh yeah, well, I'm going to go
Here's your
for that.
budget, off you go. and
Here's your
spend it where
budget.
you want.
You can buy NHS services with it, you're the expert patient now, you're in control, all this stuff, right? Meanwhile, you're keeping them away from the insurers who will not touch these people with a barge pole. They're the untouchables. Yeah? So that's the health credits, two types of health credits. Sickest of the sick and everybody else. And finally, a national insurance scheme. Yeah? Which will be, this is your NHS entitlement. Anything more than that, you will have to purchase out of pocket. And either you save up for it, you dip into life savings, or you take out top-up insurance. So most of his wish list he has achieved. This was back in 1988. So how did we get here? Well, we needed consecutive legislative change, which step by step got us to where we are. So the first changes were in the late 80s and early 90s with the setting up of an internal market under Kenneth Clarke, under the Tory party. What the internal market did was broke the NHS up into purchasers and providers. GPs were going to be the purchaser of care and the hospital would be the provider of care, rather than a health authority funding both. Yeah? And the way they did it was they set up different types of GPs, a fund holding GP and a non-funding hold GP. Yeah? So different classes of GP, and in order to keep the GPs on board, you make it sweeter for the first adopters. The first wave of fund holders, they called it, I don't know if people remember. They were called fund holders, fund holding GPs. So again, you have a gradual drift over to more and more fund holding, and then you've established the concept of, well, the GP is going to be the purchaser of care. Yeah? That ethos that we're in a universal, comprehensive, cohesive system has been chopped away at. So that's the purpose of the internal market. Within the hospital sector, the internal market got all the army of bureaucrats that were coming into the NHS familiar with charging. Although there was no money changing hands, there was this sort of fake billing and invoicing between the GP and the hospital. So that ethos is established, but completely unnecessary in a tax-funded system where the money comes from the top and you have a health authority which sends the money where it needs to go. But now we have this new charade between the purchaser and the provider. Now you can imagine how expensive all that is. And in the mid 2000s, they estimated the additional cost of running the market was about 10% of the whole NHS budget. All right? Now all the energy we waste about somebody coming to the GP for paracetamol pales into insignificance to 10% of the budget running this completely fake and pointless and unnecessary market. This is huge. So from the early 90s, the public have been subsidizing the establishment of market ethos, market bureaucracy, and board control, which took away control from the doctors and nurses and gave it to a bloated management structure. So there's two things achieved. You break the ethos and you take away control from the clinicians and you give it to the managers. So now in hospitals, I'll just finish this point. Now in hospitals you have a bloated board. You might have the odd fig leaf of clinical representation on there who are completely compliant with what's going on. Yeah, a huge bureaucracy. And on the other side, within general practice, you have clinical commissioning groups. It's all changing, but clinical commissioning groups, again, dominated by managers, accountants, and financiers, who, let me remind you, you don't need in the health system. You do not need them. The NHS functioned very well without them, and it could function very well without them now, if we didn't have this completely bogus market bureaucracy exchange.
Yeah, you're describing something that sounds like it's completely broken, which I don't recognise. Two very personal things, right? 2 years ago, my partner has made a full recovery. She had colon cancer, yeah? I couldn't have asked for better health care from the NHS. The surgery, the treatment, the chemo, the oxyplatin, yep, things are a very expensive drug, all the aftercare, and she's now 100% fixed. So that's good. Last year, about this time last year, I didn't know at the time, I got bloody pneumonia, excuse me. I had all the tests, yeah? And I couldn't complain. It was terrific. So although you're describing a bureaucratic problem behind the scenes, as a user, I don't have a problem with the NHS. I think it's great. So I'm just struggling with this. You're describing this almost dystopian thing. But based on my personal experience, I just don't see. What am I missing? Hang on.
Sure.
No.
So, again, the vast majority of people will not experience the problem unless they become acutely unwell, unpredictably, and they go to a hospital that is already extremely challenged.
What's more acute than cancer? You know,
a heart attack or a stroke.
It was a bit touch and go.
Yeah.
And she had the best possible care.
Good.
So it's not a problem. That's good.
Ask me this at the end. You're a bit premature because I haven't got to where I need to go.
It might all come to an end in next week, for all I know.
Yeah.
From my experience, I'm not recognising what you're describing.
Well, let me remind you why I'm here. I'll go back a little bit. I was working very happily as a GP and my patients were getting largely good care up until about 2012, where we'd already suffered the downgrading and closure of an A&E department. We'd lost all the acute beds, cardiac beds, all the acute surgical beds. We lost the maternity unit, and then they were threatening to close another hospital down the road. And I was already getting my sick patients being discharged home sicker than when I sent them in. You haven't gone through that yet.
I have, but that's not my experience. I'm just saying, my experience has been good.
Right? Great. That's
great.
excellent. Yeah, and still, if you're going for elective procedures, most people's experience is good. If you're having a planned hip operation or a planned cataract, experience is good. Yeah.
No, sorry to labour this. This was diagnosed cancer, colon.
Yeah.
Tumour size of golf ball, put out.
Yeah.
Chemotherapy, everything else.
Yeah.
That's not an elective procedure. That's quite a serious condition.
I'm broadening it out. I'm not using your example. I'm broadening it out to people who have elective procedures. They will not experience anything like what I'm telling you. Yeah. If you watch the news, you will see that A&E 4-hour targets have not been met for quite a few years now. If you look at the number of people who are waiting for cancer care, Yeah, they're not getting it within their 16-week target. The number of people waiting for longer for cancer treatment is gone up. All right, so these are national statistics which you can look up. I was just looking to see if I've got it among one of my slides. So I'll come back to that, yeah? So where was I? I got to the market, didn't I? These are two of my patients, all right, just to go on to your point. The lady on the left presented with painless jaundice to my local A&E department. They sent her home, they misdiagnosed her. She had to go to another hospital where she waited for 10 days on the ward, where the ward staff were saying, look, we're really sorry that you're still jaundiced and you're not having your procedure. Please can you complain because we're too afraid to complain. Then she eventually had a stent in her biliary tract and waited a further 4 months before her chemo could be given, at which point her cancer had grown beyond being operable. That's my experience. The patient on the couch is a cancer patient who's in his 30s, who developed a high fever. He has drenching sweat. He's on my couch. We ring 999 to get him to hospital as quick as possible because this is a medical emergency and he languishes there for an hour. That's my experience. And these are just two examples. But it's good to hear you had good experience. And I'm not saying what I'm telling you applies to everybody, but I'm coming up of cases of poor care or even deadly care on a regular basis now. Because where I work, we are about 5 years ahead of what's happening to you locally. Our changes took place in 2012.
Did you say Sidcup, yeah?
Sidcup.
Are you Queen Elizabeth Hospital near
Queen
us?
Elizabeth.
Because I've got a house near there, by the way. I'm going to move back. Just a little aside. The
Don't move back.
The quality of GP surgeries around here,
Yeah.
general practice Surbiton,
Yeah.
am I in Glenlyn, am I in Glenlyn? They're fantastic.
Good.
We're over in southeast London, they're
Yeah.
shocking. I mean, stark, yeah. So, personal experience.
Okay, so
You know, it's like keeping a dress here, you know.
so
Can I just jump in?
yeah.
I reiterate what this gentleman is saying. I've also had cancer. My husband's had cancer. We had first-class treatment in the hospitals. These days, if you fall through the net, you're in a problem. For some reason or another, I was under Kingston Hospital. I've been transferred to Epsom Hospital. But Epsom Hospital don't talk to Kingston Hospital. I had MRI things at Kingston. Epsom got no record of that, so I'm having to go through that track yet again. I had x-rays at Christmas. Have I had the results yet? No. Has my GP had the results yet? No.
Yeah.
Where have the results gone? Then I get a letter, I'm now having yet another CT scan. Have I had the results from that? No. Has my doctor had the results of that? No. Can I get an appointment with my doctor to find out why I was referred to Epsom, who referred me, and what is going on? So
Right.
yes, I agree, you get first-class treatment from your nurses in the hospital, your consultants, your surgeons, but the administration
The admin
side of
shocking,
it
yeah,
falls
yeah,
down
you're
to
right.
a halt.
Yeah, so what the point you have just very nicely described is the degree of fragmentation.
Yes.
These are all separate trusts with a separate bureaucracy, probably with a separate computer system that do not communicate with each other. Yeah? And you have decisions being made that are not overseen by a single consultant.
No.
It's potluck who you get to see
Yeah.
and whether the same consultant will see you through consecutive visits to go and see him. It's fragmented now.
Yes.
Well, my husband had we went to St Peter's about 3 or 4 times because he
Yeah.
had cellulitis in his leg, we found out afterwards. But every day we went back to the hospital, we had to go through the same questions,
Yeah.
and that was in the same hospital.